Welcome to American Injustice, a legal action agenda for racial disparities in health. It's part of Georgetown Law's discussion series on COVID-19 law and policy. Today's event is co-sponsored by the Georgetown Law Dean's Office and the O'Neill Institute for National and Global Health Law. We invite questions. Please do keep them short, and please submit them through the Q&A tab on your Zoom interface at the bottom, slightly to the right. We would have loved to make the questions live via voice or video, but alas, this made our cybersecurity gurus too nervous. I'm Gregg Bloche, and I'll be your moderator. I teach law at Georgetown, and in my day job, I focused on how we provide and pay for medical care, as well as on the dynamics and the ethics of the doctor-patient relationship. I've had the privilege of advising governmental entities in the US and abroad on racial and other inequities in medical care, and we do have much to do on this front in America. But over the years, I've become increasingly aware that the bigger story when it comes to health disparity isn't medical care. It's the inequitable social and environmental conditions under which we live our lives. And that's our focus today. Before COVID-19, the health policy community was painfully aware of the wide gaps in lifespan and well-being that correlate with race and class. But in the public space, it seemed this unfairness went almost ignored. And suddenly, though, the virus is spotlighting it. We've all heard about the shocking differences in COVID death rates, workplace exposure, and possibilities for staying safely secluded at home. And with astonishing speed, the murder of George Floyd and the broad protest movement it's inspired has brought attention to the social and legal arrangements that undergird racial injustice in America. This confluence and the media and political focus that's ensued has opened a generational opportunity for progress on health inequity. Less clear in our media coverage of this inequity has been the relative roles of medical care and conditions of daily life outside the doctor's office or hospital. As our panel will underscore, the latter is the main difference maker. We've structured today's event so as to briefly lay out and illustrate the main mechanisms by which social and environmental inequity begets profound health inequity. We'll then turn to the little-tapped possibilities that current law offers for battling this inequity, then to possibilities for difference-making legal change at the local and national levels. And we'll consider whether we're entering into a political moment ripe for change that could move us toward basic fairness in ways that were once deemed impossible. Each of our four speakers will offer 3 or so minutes of introductory remarks. We'll then turn to some discussion among the panelists and then to your questions. Now to our speakers, and I'll introduce them in order in which they're going to offer their brief remarks. Brian Smedley is Chief of Psychology in the Public Interest at the American Psychological Association. He was co-founder and executive director of the National Collaborative for Health Equity, as well as vice president and director of the Health Policy Institute at the Joint Center for Political and Economic Studies. Brian's been honored by the Rainbow Push Coalition as a health trailblazer and by the Congressional Black Caucus as a healthcare hero. Dana Matthew will become Dean of the George Washington University Law School next week, August 1st. She's taught law at the universities of Colorado, at Georgetown, and most recently at the University of Virginia, where she directed the Equity Center, which aims to build better relations between UVA and the Charlottesville community. Dana has advised U.S. Senator Debbie Stabenow and leadership at the Environmental Protection Agency on public health and environmental justice issues. And she's the author of the book, Just Medicine, A Cure for Racial Inequality in American Healthcare. Yael Cannon is the founding co-director of Georgetown University's Health Justice Alliance, which is a cross-campus collaborative that engages in research, service, and preparation of the next generation of attorneys and health professionals to advocate to improve the determinants of health for low-income families. Yael also directs the Health Justice Alliance's Law Clinic, which brings legal and health professionals together to provide cross-cutting services to secure housing, education, public benefits, and family stability for patients living in poverty in Washington, D.C. Sheila Foster teaches law at Georgetown with a joint appointment at Georgetown's McCourt School of Public Policy. She's taught law previously at Rutgers, then Fordham, where she co-directed the Fordham Urban Law Center, co-founded Fordham's Urban Consortium, and served as vice dean. Sheila also chairs the advisory committee of the Global Parliament of Mayors, and she's a member of the Aspen Institute's Urban Innovation Working Group. She's an advisory board member of the Marin Institute for Urban Management at NYU, and a member of the New York City panel on climate change. And so let's turn now to Brian to begin.
Thanks so much, Professor Bloche, and thanks for this really outstanding panel. This conversation is so timely and important. I'm going to attempt in 3 to 4 minutes to frame why we observe racial and ethnic disparities in both health and healthcare. Most of our audience, I'm sure, is very familiar with the fact that many people of color, African Americans, Latinx populations, many Native populations, experience a much higher burden of chronic disease than the white population in this country. This is one of the underlying risk factors and why we see higher rates of COVID mortality among these populations. But we have to ask ourselves, what is the root cause of these inequities in the first place? Most Americans, when asked about racial and ethnic differences in health, will naturally assume that there might be some genetic component or some behavioral component, such as differences in diet. We can explode those myths. Certainly we know that diet is important. Genes are important as well, but there are no discernible genetic differences between so-called racial and ethnic groups in the United States. In fact, race is a social construct. It is, in fact, a construct that we assign to people, and we assume racial identities. But the concept of race, as it's understood in the United States, is understood very differently in other parts of the world. And in fact, there is greater genetic difference within so-called racial groups than between racial groups in the United States. So what does produce health? Health is produced in our society, as Professor Bloche pointed out, by an array of factors. Health is complex, but we cannot ignore the role of social, economic, and environmental factors. Healthcare itself explains about 10% of population health. The rest is behavior, genetics, or social and environmental factors. And in fact, I'd argue that those social and environmental factors powerfully shape health behaviors in ways that we have yet to acknowledge or recognize. Let's start with healthcare. We know that there are differences by race and ethnicity in terms of access to care. This is clearly a byproduct of uneven rates of insurance coverage in the United States. People of color remain disproportionately uninsured and underinsured despite the Affordable Care Act. Even when people are able to access care, we still see disparities in the quality of health care. Professor Bloche was part of an important study panel in 2002 convened by the Institute of Medicine, which ultimately concluded that healthcare disparities are deep and pervasive, and they're found across a range of clinical services and disease areas, with people of color receiving a poorer quality of care relative to white patients. Why does this happen? Many complex factors. Among the factors that researchers are beginning to investigate and to better understand today are factors such as medical apartheid, what's been called medical apartheid, separate and unequal health care for people of color relative to whites. It's still true that people of color are largely seen in healthcare systems that are under-resourced and struggle with some quality challenges. Aside from medical apartheid, we see other factors. We know that even in the same health systems, people of color can receive a lower quality of care than white patients. What explains that? A wide array of factors, but among them are factors such as both explicit and implicit biases, attitudes, assumptions, stereotypes about patients, which physicians and other healthcare providers may be consciously aware of or not, and they can infect the clinical encounter. Beyond healthcare, what are the factors that we see? Certainly there are differences in environmental exposures. And here I want to point to an important factor that is often unrecognized. One of the major sources of structural forms of racism is residential segregation. Residential segregation is a major factor behind the phenomenon of medical apartheid, but it also powerfully shapes who is exposed to what kinds of environmental health risks and who has access to health enhancing resources. Too often, residential segregation leads to high levels of poverty concentration in communities of color. These communities are under-resourced. Historically, many of these communities have been under-resourced by deliberate disinvestment, policies and practices such as redlining, which have led to continuing economic marginalization even to this day. And in fact, in some of the research that I've done with colleagues, we've looked within the same jurisdiction at communities, census tracts that were formerly redlined in the 30s and 40s, and find that still today, those are the census tracts with the lowest life expectancy relative to more advantaged tracts. Why does this happen? An array of factors. Environmental factors, such as sources of environmental degradation from polluting industries. Think of the policy decision made in Flint, Michigan, when a water source was switched for residents of Flint, Michigan, exposing them to high levels of contaminated water with lead and other chemicals. This happens too often in highly segregated communities of color. These communities are often characterized as food deserts, lacking access to healthy, nutritious, affordable foods. Conversely, many of these neighborhoods are oversaturated with vendors selling harmful products, such as takeout food, fast food, convenience stores selling high sodium, high fat, high sugar products. So these are among the factors that also help to shape the dietary behavior of the residents in those communities. We also see that in highly segregated communities, school systems are deeply inequitable, which constrains economic mobility and opportunities for educational advancement for the children that are in those school systems. Few people recognize that today, some 60 years after the Brown v. Board of Education decision, today our public schools are more segregated than they were in 1954, the result of massive political resistance to school desegregation efforts. And this too is a major social determinant of health for people of color. I've prattled on too long. I appreciate this panel and this opportunity. I'll turn it back to Professor Bloche.
Thank you very much, Brian. And Dana Matthew, you're on.
Well, I appreciate being able to follow such a comprehensive explanation from Dr. Smedley, and I thank you for the opportunity to be on this panel. I want to focus my 2 minutes worth of comments on the role that the law has in both constructing and maintaining the very inequalities that Dr. Smedley was referring to. I'd like to suggest that the punchline here is that it is because of the legal structures that I'm going to call structural racism that were historically created and that are contemporarily maintained that the health disparities we're looking at cannot be reversed unless we actually reform the law. That is the fundamental cause. So I'll use the South Bronx, which is my hometown, as an example. And before I do, I'll just give you a word picture. Everybody's familiar with Flight 1549. That's the US Air jet that went down under Captain Sullenberger's great piloting in the Hudson River in the middle of January. It was freezing cold, and everyone on that plane, 155 souls, survived. The greatest number of people who survived on the wing of the plane. So had they been in the freezing Hudson for very long, they would have been dead. The few people who were in first class had a raft, they had a life jacket, they had rations, they had a flare, and their life chances in the Hudson River were better. Why? Because of their place on the plane. Because of their place mattered. I want to emphasize that your place in society today was legally constructed. In other words, right after the Civil War, people did not separate by race and by ethnicity. Reconstruction was a period during which whites, blacks, and others lived together. What happened in the 1900s was a legal deliberate separation of people. And ever since those segregation ordinances have been instituted, we have repeated and revised the legal separation, whether it was zoning ordinances or vagrancy laws or restrictive racial covenants. Structural racism continues to divide us, and once we are divided by place, all of the resources are also divided. So let me give this definition of structural racism. It is the hierarchical sorting of people based on this social construct that Dr. Smedley referred to by race, in order to accomplish two things. One, to make some inferior and others superior, and two, in order to allocate resources. We do both of those by law. Historically, by explicit laws that were legally segregating and dehumanizing, but make no mistake about it, those laws continue today. They continue in the form of under-enforcement of all of the anti-discrimination laws that were passed during the 1960s. I'm talking about the Fair Housing Act, the Voting Rights Act, the Education Opportunity Act. I'm talking about Title VI of the Civil Rights Act of 1964, Title IV of the Civil Rights Act of 1964. No sooner than the ink was dry on these statutes that our courts have begun to reverse the equality promise under our Constitution. That is the underlying fundamental reason that we have health disparities today, and unless we reverse those laws, we will continue to have them. I'll close by saying that the COVID-19 virus and the pandemic has given us an opportunity. We have an opportunity to face squarely the structural inequality and the structural racism that has been revealed by the disproportionality of morbidity and mortality affecting minorities, particularly Native Americans, African Americans, and Latinx populations in the United States. We can see that their underlying comorbidities are a reflection of the place matters story that I told at the beginning of my comments with respect to the plane. If you are stuck in the South Bronx with bad schools, poor food, the high violence, and other structural inequalities, you are in the wrong place at the wrong time, and COVID-19 has shown us that that is deadly. So structural racism makes people die quicker and live sicker, and that is why we should reverse it.
Thank you very much, Dana. And if you've heard thunder during Brian's and Dana's remarks, although perhaps the heavens are underscoring their important points, there's a fierce line of thunderstorms going over where I am right now. And thanks also for setting the table, I think, for Yael's remarks about what we can perhaps do in the here and now. Yael Cannon, you're on.
Thank you so much. I want to build on Dr. Smedley and Dean Matthews' remarks by zooming us all the way into the life of one family that I've gotten to know really well. I'm going to call them the Brent family. So a few years ago, the Brent family walked into the Hoya Clinic, which is a health clinic run by Georgetown medical students in a homeless shelter. The family had been evicted from their apartment, and the two parents and three children had been homeless for 2 years. They were facing housing discrimination, which Dean Matthew referenced, in the form of violations of the Fair Housing Act and local DC human rights laws when they were trying to use a voucher to rent an apartment in Washington, DC, and they could not get out of shelter. When the family came to this health clinic, they got a legal checkup by medical students who asked about legal issues that could have an impact on their health, including questions around housing discrimination. They referred the family over to our law students in the Health Justice Alliance Law Clinic for legal advocacy. We fought that housing discrimination, and we got the family out of shelter, and we got them housed. They were doing great, and then came COVID-19. Their Washington, DC neighborhood has been completely ravaged. Mr. Brent lost his job, the kids were hungry, and Ms. Brent called us back saying that she and her husband have been skipping meals so that the children can eat. The family fears being evicted and becoming homeless again. And we know that homelessness and hunger are two factors deeply connected to health, and particularly impactful in terms of their adverse consequences for children and on child development. So before I tell you what happened to the Brents, I want to set the scene in their neighborhood for you. So they live all the way at the bottom of Washington, D.C., in DC's Ward 8 neighborhood, which is over 90% African-American and very high poverty. Average life expectancy in that ward is 15 years shorter than Ward 3 in Washington, D.C., where Georgetown University's main campus is located, which is the highest income, predominantly white ward in the city. So how is it that in our city, we can take a metro ride across town and people are dying 15 years earlier on average than their neighbors just up the metro line? Well, that has everything to do with the social determinants of health that we have been talking about today. So in Ward 8, there are poor housing conditions. We have helped families with lead in their water and in their paint. There's mold in housing, exacerbating asthma for many of the children we see. There's high unemployment that's only been exacerbated by COVID. There's food insecurity. The neighborhood is a food desert, as Dr. Smedley has described, where there are very few grocery stores. The schools offer lower quality education and families experience chronic and toxic stress. And in the midst of this pandemic, Ward 8 has only 11% of DC's residents, but more than 20% of the COVID deaths. And these same social determinants of health contribute to the disparities that COVID has been exacerbating. So the families we serve in that neighborhood, they're more likely to have essential workers in their family. They're more likely to live in a dense neighborhood, in a dense apartment building, in a multi-generational household. They're more likely to rely on public transportation to get to work, or to get the multiple stops that many of our families have to get on the bus to get just to a grocery store. And all of those things make social distancing and staying safe during COVID very difficult. Okay, so we have depressed you guys significantly. What is the good news? So I think there is some good news. And part of it is what we see in terms of the impact that our law students and our lawyers can have in helping families like the Brents actually achieve health, and also in shaping law and policy to address disparities. So just to illustrate the impact with the Brent family. So our Health Justice Alliance law students and lawyers helped Mr. Brent appeal the denial of his unemployment benefits. We took a look at the whole public benefits picture for the family and determined that they actually weren't receiving the full amount they were entitled to in food stamps. And we advocated for that increase as well. And we worked with the landlord and the DC Housing Authority to negotiate a reduction in their rent. So we enforced the laws that we have on the books to the full extent in the way that Dean Matthew was suggesting. And so in our work, we see not only the need for drastic law reform, but also the need to enforce the good laws that we do have on the books to their fullest extent for some of the people who are most marginalized in our city and throughout the country. So after this advocacy, I'm happy to report that Ms. Brent called me back and is really thrilled that the family's not hungry anymore, that they have the income to last their meals through the end of the month. They have avoided eviction, and they are healthier and have better well-being because of it. And this is the medical legal partnership model that is growing across the country. And we have a lot of families that we serve who live in public housing complexes and other low-income neighborhoods throughout the city, where a mobile pediatric van pulls up so that kids can have easy access to healthcare. And those families get a legal checkup when they go to the doctor's office. And then our med students, law students, and nursing students collaborate in the way that I've described to help the Brent family. Before I turn it over to Professor Foster, I just want to end by saying that I'm also heartened by a few pieces of legislation that have been introduced in Congress recently. So one is a bill promoting the role of lawyers in actually addressing these health disparities by calling for a civil right to counsel. So understanding that as we are about to face a tsunami of evictions across the country, that before somebody loses their home, they have a right to have an attorney next to them advocating for them in court, just like all the landlords out there who are seeking to evict, who always come to court represented. And the other bill I want to mention just contemplates kind of a unique role for the CDC, which I know is kind of a hot topic right now, in actually promoting an understanding of health disparities and social determinants of health and funding grants to public health agencies and nonprofits and universities across the country to develop evidence-based practices to actually work on some of the issues that we're talking about today. So I'm also heartened by, some of the action that we see, in Congress recently around some of these issues. Thank you.
Thank you very much, Yael. And Sheila Foster.
Sure, great. Well, it's humbling to follow these speakers, but let me try to build on what everyone has said in the following manner. First of all, I think it's right that COVID has presented an opportunity to focus on these issues, but also kind of a window into why we're in the situation that we're in. So I've worked, as has Dana, in the field of environmental justice for many, many years. And one of the things we've focused on is bringing attention to how do you create healthy and sustainable communities. So in the environmental justice area, we define the environment as the places where people live, work, play, and pray. The COVID pandemic has shown us that all of these places have been places of risk and danger for folks, right? So Yael just talked about multi-generational households, all right? New York City was a hot spot, including the South Bronx and Queens. The downtown Manhattan, most people fled because they have money. They were also overwhelmingly not people of color. But the people where, or the communities where low-income and minority folks lived, right, lived in multi-generational household and sometimes substandard housing. So the places where they live, we know now that that is a risk for infection. They were essential workers where they worked. They had to get on the metro, the subway every day to go to those jobs at a time when the rest of us could shelter at home or shelter in our country homes. Where they play, well, these communities don't have places to play because they lack green space and other amenities, right? First, we were told to shelter at home. Home is risky, but now go outside. The weather's getting nice, hang out on the green. I can walk to the green from my apartment, but in many communities, there is no proximate green space. Worship. We also know that super spreading events happen indoors, not just bars and restaurants, but places of worship. So the places where people live, work, play, and pray have become the most dangerous in the most vulnerable communities. So that's point number one. Number two is, instead of focusing on the ecology of, I think, spatial inequality, we focused on people's behavior, right? What Brian Smedley was talking about, to suggest that comorbidities, the way people live, they have asthma, they're obese, they have diabetes, they have all these lifestyle factors. And that's why some people were more vulnerable than others. Well, it's time to tell the truth about that, right? Related to the first point, why are these comorbidities more present in these communities? Number one, as Yael just talked about, lack of access to healthy food deserts, for instance, and relatedly, lack of investment in really capital-starved communities, right? I started out my teaching career in Rutgers, Camden, and the thing that always struck me about Camden, not just that it was one of the poorest and blackest communities in the country, but that it didn't have a grocery store, right? The students at the law school had to leave Camden to go to the suburbs to shop for food. These are segregated communities that are locked into segregation, as Dana talked about, right? Because of not just the history, right, but ongoing lending practices. Think about the foreclosure crisis and ongoing housing discrimination that really has locked folks into these communities, right? Environmental pollution. We know that COVID infection and death rates are connected to levels of PM 2.5 in communities. Communities that have high levels of PM 2.5, like the South Bronx, are those that were hit the worst and had worse outcomes. And we also know, so a Harvard Public Health study made this connection, but we also know from previous studies that levels of PM 2.5 and race are highly correlated. And then, of course, poor housing conditions. The last point I would make is that, so as lawyers, what do we do about this, right? So all of us as lawyers have worked on unraveling or undoing, unlocking in the locked-in nature of spatial inequality. And I want to focus on three potential interventions, one of which the Trump administration just announced today that they were doing away with. And that is the Housing and Urban Department, HUD's affirmatively furthering fair housing rule. First, they said they were going to study it. Now they're going to do away with it. Why is that important? Because this is part of the Fair Housing Act that's not enforceable in court, but that is a tool that federal agencies that supply housing and that ensure fair housing have to make sure that the recipients of their programs and funds do something about quality, affordable housing. That rule that the previous administration worked up into a rule and also a set of resources, including data, to know what's happening across the country has now been disbanded. But that's exactly the kind of intervention we can make. Secondly, Dana talked about the Title VI of the Civil Rights Act. Which basically links federal funding to non-discrimination guarantees. If local and state agencies are receiving federal money and they're not doing their job in opening up access to opportunity, putting parks in neighborhoods, we should be defunding them. The federal government should not be defunding them. Okay, so that's the federal level. Much of the law happens on the state and local level, and that's what Yael was talking about. Two things there, zoning changes. So the reason polluting facilities in these communities are overexposed to pollution is because our local zoning laws tolerate it, right? They tolerate segregation, they tolerate not putting multi-unit housing. So in suburbs, and by the way, Minneapolis has just done away with single family zoning to open up access to opportunity for households that aren't buying single homes, but are buying apartments. Why is that important? Because apartments often are more affordable, of course, not in Washington or New York City, but the rest of the country. So it's important to open those up. And finally, federal and state environmental laws in risk assessment use white male bodies to measure the risk of exposure to certain things like lead and other pollutants that's consistently overexposed minority and poor populations to pollution, even when we have good laws and standards. So there are lots of opportunities to undo this locked-in segregation, to undo this locked-in disadvantage that I think COVID has exposed, and we have the tools for it. And so now is the time for action. Thanks.
Thank you very much, Sheila. And to leave some good space for questions, let's perhaps let's make our discussion about 5 minutes. And does anybody have any reactions to things that others have said that you might voice now? Okay. Jump in. No blue Zoom hands are necessary.
Well, I'll start. I'll just say that there's an amazing consistent thread throughout all of our comments that I really thank you, Gregg, for bringing us together to talk about law at various levels, whether it's for the Brent family, whether it's zoning laws, whether it's federal laws, whether it's enforcing or changing laws. There's a unanimity among us saying that a key part of the solution is to use the law to its fullest extent, as Yael was saying, and to reform the law to the extent that it has gone awry. I think I'll take this opportunity to be a little bit provocative about another set of bills that have been introduced, and those are the bills for reparations. And I'll say that they are health related as well, as all laws are. And I just want to tell you that there is empirical evidence that as our laws become more and more equal, that we become more and more serious about enforcing equality, health gets better. The gaps between Black and white and Latinx shrink. And as our laws become unenforced and ignored, the gaps widen. So law is fundamental to this answer.
Anybody else?
I guess I would just...
Oh, go ahead, Brian. Sorry.
Sure. I just want to underscore what Sheila said. Today's announcement that the administration is undoing the affirmatively furthering fair housing rule is really tragic. This was a mechanism whereby local housing authorities working with communities would develop solutions for the segregation that has been so deeply baked into our neighborhoods, creating incentives for more mixed income housing, finding ways to promote housing mobility strategies. The housing mobility is really key here because we have constrained options for housing for so many people of color historically, leading to this phenomenon of being locked in. There are ways to improve options for people to be able to move to and live in neighborhoods of their choice. And this can be particularly helpful for young children. We have strong empirical evidence that when families move out of high poverty neighborhoods, particularly young children on a 15-year randomized controlled trial follow-up did much better than their peers that remained in deeply poor communities. Families had higher levels of income. They reported lower levels of stress. And from a health standpoint, families reported lower levels of chronic, of severe obesity and other diseases. So housing mobility in itself is a health equity intervention.
Let me
If I
raise.
can- sorry.
Go ahead. Yeah.
I was just going to say that the Brent story illustrates that perfectly because when they were in shelter and we were trying to figure out what the barriers and legal obstacles were, they tried to rent in neighborhoods that were higher income, where the schools were better, where there were grocery stores, where there were safe and healthy housing conditions. And they faced discrimination again and again and ended up, you know, in one of the lowest income areas of the city, you know, residentially segregated, like their neighbors, you know, confined to a part of town where your zip code is essentially a death sentence. And we see that even, you know, more now during COVID. So I just wanted to bring it down to that level because I think we really saw that play out, and we see that play out with a lot of the families that we work with.
A related question. This morning, there were reports that Mitch McConnell and Senate Republicans were close to releasing, they may have even already released it, that's unclear, close to releasing language as part of the next COVID relief bill, at least the Senate version, that would make liability for employers much harder to achieve. It would raise the standard for liability from the standard tort more probable than not standard to clear and convincing evidence. And it would shield employers from liability to their employees or to others if they could say that they took, that they made a reasonable effort to comply with public health standards without defining public health standards. If we're in an environment in which it's a whole lot easier for meat packers and the folks who run big box stores and lots of other businesses to put the heat on their workers to return to these non-shielded jobs with diminished risk of liability for these big employers, what contribution might that make to the kinds of disparity we're talking about now?
I would just say that that underscores, I think, the loss of a social contract in society, right? To take care of each other. I think, and let me say something provocative, which is to say that the vast majority, proportionally, of folks that have been impacted by this virus have been the most vulnerable populations, including African Americans and Latinx, but also the elderly. And a lot of people would read the current environment, and I think the liability rule speaks to that, as basically a shrug. That those folks are, dispensable. In fact, there have been elected officials that have said, my grandmother has lived long enough. Old folks have lived long enough, and maybe it's their time, right? At the beginning of the epidemic when, or the pandemic rather, when it was clear that, for instance, the elderly were being hit hard. We actually saw elected officials from some states get on TV and say things like that. So there's this a loss of a social contract to care for each other, and particularly when each other is the other, right? The other, the people who you don't have contact with because we live in segregated communities, and the poor and the minority. So I'll stop there. So that doesn't surprise me, unfortunately, in this current environment.
Another audience question. Many people disregard the COVID pandemic completely. Others don't take public health measures seriously. What role do individual and community behaviors and attitudes play in disparate health outcomes for different racial and ethnic groups? And anybody who'd like to take that question.
You know, it is fascinating, Greg, to see the political dynamic at play here. We know from a large body of research in public health that communities that are cohesive, that come together to solve their challenges, what we call collective efficacy, is so important, particularly during times of a pandemic. What we're seeing in the US is the opposite. We are seeing elected leaders fomenting division. We have seen a resurgence in overt expressions of racism and xenophobia directed at many communities, such as the Asian American community, as well as Black and Brown. These are the very conditions politically that are going to make the pandemic worse. And I think it's one of the reasons why we've seen in the United States an uptick in infections, whereas almost every other developed country is seeing a flattening of the curve. So we're arguing that in addition to physical distancing, equity flattens the curve. If we don't get that right, we're going to leave some communities vulnerable, and the virus will remain with us.
Thank you. Thanks a lot. Anybody else on that?
Yeah, if I may, I want to underscore the two last points, the social contract point and the fact that equity flattens the curve. There's a lot of empirical data that supports both of those points. We first have to, I think, interrogate what we are calling essential workers, to your question about the recent liability rule. What makes these people essential is that we are all together dependent upon the person who goes to work on the metro in order to stock our grocery shelves. Ironically, the person who picks our strawberries and our vegetables, who the day before the pandemic was undocumented and pariah, and after the pandemic hit became essential and had to make sure that they were in the fields making it possible for us to have our groceries delivered at home. These rules separate us in a way that ignore the data that tell us that racial division, racial bias, and racism kills all of us. Racism is bad for all of our health. We are able to see that geographic locations which have a high density of Google searches for the N-word also have higher mortality rates for Black and white communities, higher infant mortality rates for Black and white communities when we see that there are locations that have high implicit bias and explicit bias ratings. So this broken social contract is not relevant simply to the quote unquote disposable among us. But in order to dehumanize any of us, we dehumanize all of us. So the fact that we are ignoring and shunting the weight of this pandemic off is going to inure to all of our detriment, and we do it to our peril.
Thank you. Thank you. That was powerfully said. A question from Politico. Is there, to what extent might there be a technological solution to some of these challenges? To what extent might technology be used creatively to try to ameliorate some of the disparities we've been discussing?
Well, a lot of potential, but again, to interact or to make the connection with inequality, the digital divide, I think stands in the way. And we see this in public schooling right now, and trying to school through Zoom, right? Localities have been, frankly, chasing their tail a bit, trying to get students the basics to be able to participate. Because the one ways that technology has helped is to keep us away from places and also out of contact with people who may be spreading the virus. But in order to reduce disparities, to flatten the inequality curve, folks have to have access, right, to that technology. So back to Dana's point, I mean, racism is a public health crisis, and it also will be our undoing. So we've got two pandemics that are interacting here, right? Racism and COVID. And we can't just deal with one no more than you can deal with the economy and not the public health crisis. So I think technology is at that intersection as well.
Thank you, Sheila. Question from Robin Jimenez. Now that protesters have the attention of the rest of the world, what can and should citizens do to demand and ensure equality in healthcare? What is step one, especially right now during COVID?
So I believe, quite frankly, that keeping the heat up hot and heavy is step one. I think step two is making sure that everyone that fogs a mirror, is registered to vote, goes to the polls, and make sure that they take someone with them in November. I think that's step two. We get the leaders that we deserve. If anyone thinks their vote does not count or that the system did not need a participant, you have lived through evidence that that is incorrect. So those are two steps I would endorse immediately for those of us that want to see change.
Thank you very much, Dina. Another question, this is from an unidentified person. Is it too vague when the media says, quote, Black and brown people are dying of COVID, unquote? Is there a particular class or geographical reason? Is it the elderly? Can you shed more light?
So the media, in my view, needs to do a better job reporting on racial and ethnic disparities. They've got to be clear on why we have higher rates of chronic diseases in Black, brown, and Native communities. And so clearly understanding the role of race and racism in creating risk is important. But we also have to be aware that while we typically see a socioeconomic gradient in most illnesses, that is, people with higher levels of education or income typically have better health. In this instance, we simply don't have the data because we don't have a national strategy for data collection and reporting that provides demographic information. We're getting some race and ethnicity data from some states. In too many instances, the data are missing or incomplete. And so until we get a full understanding of race, educational attainment, income, primary language spoken, and other fault lines, it's not clear to the extent which different economic classes are at risk. But we certainly know, as has been pointed out on this panel, that in highly segregated communities of color, where typically residents are much more likely to have low incomes, that these communities have been at risk for a wide range of reasons, including the kinds of work that these folk are relegated to.
Let me just add one quick data point, because actually the Furman Center in New York at NYU studied the outcomes in New York, actually. And it's interesting because they found that controlling for poverty in education, right, that the poverty rates in neighborhoods with high and low infection rates were similar, but still Black and brown communities on average had higher cases and deaths. They found the share of adults with college degrees was relevant. It decreased as the prevalence of coronavirus cases increased. And again, they found that COVID is more prevalent in areas with certain markers, geographical and other markers of multi-generational household, how many essential workers. But the idea that poverty explains, I think, the racial disparities is, at least for one initial hotspot, was just not proven, even as there are other indicators of that actually don't map onto poverty, but unfortunately map onto race.
A question that follows up on what both of you just said, from Richard Waugaman. I may have pronounced your last name incorrectly, Richard. I apologize if I did. And this is to Dana. How would Dana feel about minimum guaranteed income for everyone living in poverty as a form of reparation, Richard asks.
So that's an excellent form of reparation to start. There are several really, I think, salient approaches to reparations that make a lot of sense. Look, when we look at the end of Reconstruction, the end of the Civil War, the property value placed on human beings who were African American, who were Black bodies, exceeded the wealth of all other forms of industry. It is very easy to build a country when you have free labor and never, ever have to pay for that. So guaranteed income is one way. Making sure that ancestry is connected to enslaved bodies is another important criteria. Making sure that because race is simply a social construct, it has no biological meaning, that you have, by identifying yourself in the last 10 years as a member of the community descendant from slaves, is important also. Look, there's no shortage of the ways to do this. We've done it with Japanese reparations, reparations for internment. We can do it again. And so I think I would not only endorse that, but I want to pivot to another point that's been made by other panelists, and that is we should also be very clear that socioeconomic status does not explain the racial differences that we are seeing for a number of reasons. Just let me list two. We talked about residential segregation. African Americans, no matter what their income level and education level might be, are the most segregated population in this nation still, right? So African Americans who are middle income and college educated are more likely to live next to neighbors who are low income than even white low income populations in some parts of the country. So the concentrated deprivation of place affects people no matter what their income level and affects them by race. Secondly, the point I made earlier about racism being detrimental to all of our health is very important with respect to understanding the data that tells us. I'll take infant mortality, for example, that the gap between Black and white infant mortality, which is 2.5 times generally across the country, does not disappear when we control for income and for education. So that in some states, Colorado being an example, where a Black woman is college educated and making between $50,000 and $75,000 a year, she remains almost 3 times more likely to lose her child in the first year of life as a white woman who has not finished high school and lives below the poverty level. So we really do have to consider these issues with respect to the salient social determinants that have been allocated by law according to race, according to ethnicity.
There are a fair number of conservatives out there who have long pushed back against efforts to act on social and economic determinants of health by saying, well, life is unequal and the economic outcomes are unequal, etc. And the fact that health outcomes end up being equal as a consequence is just part of that story and doesn't merit any greater consideration, say, than the fact that some people drive Chevys and other people drive BMWs. Plainly, those of us, all five of us, don't share that perspective. But how do we answer that argument?
Sure, I'll take a shot at that, Greg. So clearly the moral argument here is not persuasive. Many of us believe that just as a moral issue alone, we ought not to tolerate the deep inequities in health that we see. But let's talk about the economic argument. A few years ago at one of my former organizations, the Joint Center for Political and Economic Studies, we released a study that looked at the economic consequences of racial and ethnic health disparities, the fact that people of color live shorter lives and are often burdened by higher rates of chronic disease. Well, that has implications for productivity. It has implications for our tax base. If you're too sick to work and can't contribute to your part of your paycheck to our tax base, that's a problem. If you're dying sooner than you should, and your family struggles economically as a result, all of these have economic costs for the entire society. Our estimate was that in the 4 years between 2003 and 2006, racial and ethnic health disparities, inequities, cost our country $1.24 trillion. That figure is likely higher today, given that that estimate was some 14 years ago.
I would also say that taking that argument just on its face, one of the dangerous things about this era is that we can make arguments without ever having to substantiate them, right? And we can call things fake news that we don't agree with or fake data. But everything we said on this call is backed up by data and shows that that argument taken on its face assumes a neutral system, some kind of market that has an invisible hand that gears, and an opportunity structure that's neutral, actually. And everything we've said indicates, and it's backed up by data, that that's just not so. So even if you want, morally, you agree with that argument, you also have to buy into empirically the underlying assumption that we have a system that will just churn out outcomes as it's like let things fall where they are based on the inputs, hard work, et cetera. But we don't have that system. And frankly, we've never had that system. What, Dana basically explains that we've had a system of racial capitalism, right? Where everything we've built has been built on the labor of African Americans and slaves, and now on immigrant populations and also indigenous populations. So what we're talking about is a system that you have to fix in order to generate the kind of outcomes that look fair and just.
A question which we may well conclude on. We're going just a few minutes over. And my apologies to the many of you who've asked really good questions that we have not had the opportunity to get to. I've tended to steer towards the determinants of health questions over the health care questions, since this event is mainly about the former topic. But the last question, again, it's anonymous because the questions that were pre-entered before the event began didn't come to me with people's names on them. In the face of the discouraging reality, and I'm reading almost verbatim here, in the face of the discouraging reality of how much justice in this country is dependent on custom and the goodwill of decent, moral, and values-based leadership, and less on protections of our Constitution or laws, as many of us believed only a few years ago, what beacons of hope can we hold on to for faith and confidence that justice in health is still achievable, especially should the country lack such leadership at the national level?
I'm going to take a shot, and I hope someone will also have the last word after this. In a very ironic way, the collision of two pandemics have given us an opportunity that also, I think, represents hope. We have a global health pandemic that has paused us and caused us to have the time to reflect on the racism that we have seen, not because it's new. Let me be clear. The fact that George Floyd died on television was not new. The fact that Ahmaud Arbery was killed in the street was not unusual. That happens. The fact that Amy Cooper used her white privilege as a weapon against an African American happens every day, but we were on pause to see it and to reflect upon it. And the hope I have is that the broadening of the recognition of how deadly racism is in our society crosses over those place barriers of segregation, crosses over the separation and isolation that has happened in our schools, and has brought out into the streets a widely diverse group of people saying Black Lives Matter, a widely diverse and young group of people saying this is not the society that we will accept. I hope that this is an inflection point, and the hope that I have is that this will be sustainable, and frankly, that we will swing for the fences to change the country that we have into the country that we say we want it to be.
And I'll just add, I mean, I think one of the beacons of hope is new leadership in the young folks, not just in the street. But I think about the young mayors and the governors that have shown us. For instance, someone brought up UBI. Mayor Tubbs, this young African-American mayor in Stockton, California, has been running that experiment and now has mayors all over the country, rather, who are joining with him in a network to try UBI as a response. Defund the police is really a request of the government where you live to reallocate funds to take care of communities and to make them healthy and sustainable. And we see leadership rising to the challenge. So for me, it is young folks and local and state leaders who, notwithstanding the disappointment at the federal level, are showing us that all politics is local.
Well, thanks all hugely. I guess I conclude with maybe a little bit of additional hope out of something awful. The ugliness that we have seen at the highest level, both the rhetoric and the action from Mr. Trump and those who abet him, and the ugliness that we've seen in the streets has shocked a hell of a lot of people who kind of thought that we were a couple generations beyond this, and that the civil rights movement had done that work. And it might just be that the vileness of it all causes the kind of reaction that leads people to say, I don't want to be associated with that, and I want to be part of the more fundamental change that's going to put that behind us. The loathing of, Mr. Trump's behaviors might kind of more generalize into a broader support, and a broader support that might lead to the next great generational surge forward. That's a hope, and beyond that, we shall see. And we're not supposed to be political, but but what happens on November 3rd and in the perhaps days and weeks beyond is going to play a role. Thanks, everybody. Thanks to our wonderful panelists. Thanks so much to our audience and your great questions. And I'm just really sorry that we weren't able to bring you in, verbally and through video, and bring in more questions through the written submission mechanism. Bye-bye, and best of luck to everyone. And please wear a mask when you are outside. I meant to begin this session with my Phillies mask, but alas, I didn't bring it along with me. Bye-bye.
Bye. Thank you.